Hi, this is Anwaar Saeed. I'm a GI oncologist at the University of Pittsburgh Medical Center and UPMC Hillman Cancer Center. I recently joined UPMC as the Chief of GI Oncology. I have particular interest on immunotherapy and immune modulatory approaches in GI malignancies with focus on upper GI malignancies and colorectal cancer. Previous to joining UPMC, I started my GI oncology career at the University of Cancer Center, where I also served as the Associate Director of the Early Phase program there. It is my great pleasure to be here today with Manju and my colleagues to discuss colorectal cancer advances and updates from the recent GI ASCO meeting. I'll present some immunotherapy advances that's been presented or highlighted at the GI ASCO meeting this year. So I'll start with the Bot+Bal updates on that study that was presented by Dr. Al-Kuwairi, and it is testing botensilimab, which is a novel CTLA-4 inhibitor with an Fc-enhanced portion, or the Fc portion is enhanced to make it a novel CTLA-4 inhibitor that enable better adaptive and innate immune responses. And it is combined with a PD-1 inhibitor called balstilimab. So in this study, which I think Dr. Al-Kuwairi presented the results of this study in the previous meeting, but in this meeting, he presented a follow-up or mature results from the ongoing study. It is testing the combination in patients with refractory metastatic colorectal cancer who are microsatellite stable. They allowed, those patients were heavily pretreated and they allowed prior immunotherapy exposure. So the results showed impressive results for an IO-IO combination here. So the overall response rate was 23% with disease control rate of 76% and a median PFS of 4 months in the overall population. When they looked at overall survival and then subgroup analysis, they've seen that there's a great difference between patients who have liver metastasis versus those who do not have liver metastasis. As you see here in the 12-month overall survival was 40% in those patients with active liver mets versus 81% in those with no active liver mets, showing the combination worked better in those patients who do not have liver metastasis. And prior to highlighting another study, I would like to highlight the safety profile of the combination. Whenever we think IO-IO combinations, we think it's an easy regimen to consider, but we have to keep in mind that those doesn't come without toxicity, including financial toxicity here as well. If you look at the grade 3 toxicities here, we're talking about 40% grade 3 toxicities, including 20% of them diarrhea and colitis. And I'm focusing on grade 3 because when it comes to quality of life, we have to look at those. And it's comparable to what we see with, if not higher than what we see with VEGF-TKI, IO combinations that I will highlight next. Another thing about this study is, the overall results of this study, considering that there is a good portion of the patients who went on the study did not have liver mets, the overall results is impressive for an IO-IO combination when we compare the results historically with prior IO-IO studies that was done in the same population. For example, the Durva-Trimi study that was done in Canada, and I believe published a couple years ago, did not show much responsive in the microsatellite stable population, and this similar kind of refractory setting. And so 20% overall response, including good, stable disease, when the population included some liver mets, is impressive. So the question is it this novel CTLA-4 inhibitor leading to the improved responses? Is it the disease biology of this population? As we all know, in all of those small studies, the colorectal cancer heterogeneity in terms of, sidedness, the enrichment of certain RAF mutations, liver, non-liver mets play a huge role in what we see. So things to keep in mind. And then the other studies I would like to highlight is the IO+TKI combinations, which in this conference we touched on the RIN or regorafenib, ipilimumab, nivolumab, and Rigo-Nivo data from Dr. Faqih at the City of Cobb. He presented those data at prior meetings, and in this meeting he had a poster presentation with a follow-up for more mature data. So similarly in this data, there is some, the responses and the benefit was kind of limited to those patients who do not have liver metastasis, whether we're looking at the Rego-Nivo data or the Rego-Ipi-Nivo data. With the triplet, there is some inflation in the response rate, so more deeper responses seen with the addition of ipilimumab. But similarly, even with the triplet, there was not much responses or benefits seen in those patients who do not have liver metastasis. And this is from his 2022 ASCO presentation. And this poster presentation at this meeting, the follow-up data showed similarly, looking at RECIST and those patients without liver metastasis did way better than those patients with liver mets. He also did some ctDNA, serial ctDNA at baseline and 4 to 6 weeks post-therapy, and he was able to demonstrate that those patients who show a depression of ctDNA are the ones who have longer responses on the study, kind of another marker to look at to identify responses while on a study using liquid biopsies. And I wanted to, again here, it's a VEGF-TKI combination, so just to look at also the safety of the combination. So the grade 3 toxicities here, 40%, grade 3 toxicity among the patients enrolled. This is for rash, and there are also 10% hepatitis and some others. So things to keep in mind. It's kind of in line with the IO combination. And then there are several, as you all know, VEGF-CRC kinase inhibitors, IO combinations that was tested and presented, like beyond regorafenib, lenvatinib, IO, as Kathy presented, was showed in an early phase 2 cohort that there was around 22% responses. This was taken to phase 3 in the LEAP-017 study. The study has recently completed enrollment, so we're looking forward to the results from that. This is an all-comer kind of cohort, so I do not believe that the study was tailored to a particular group. And then the STELLAR-303 is a study testing the next generation VEGF-MET tyrosine kinase inhibitor, which is the next generation of cabozantinib. Based on the 2 trials that tested cabozantinib plus IO, the Camilla trial, and tested cabozantinib plus durva, and then the other one that tested cabo with the atezolizumab. Both of them showed some responses, but more profound responses seen in those 2 studies in patients who have RAS wild type. And so those results were taken into phase 3 trial, STELLAR-303, and chairing the study along with Dr. Hecht from UCLA. And this study combining XL092 plus atezolizumab versus regorafenib in patients with metastatic colorectal cancer and tailored toward the patients who have RAS wild type. So 2/3 of the patients that will go on the study will have RAS wild type. So that will help us know if RAS is doing anything in terms of immunotherapy responses. Another thing I would like to highlight, and we highlighted this in the immunotherapy session, my friend Dr. Amin did a really wonderful job in highlighting, immune combinations and what are we looking at in the ongoing trials. So there are other checkpoints, other immune checkpoints beyond CTLA and PD-1 or PD-L1, and the ones that are being tested, the drugs that are being tested against those checkpoints are anti-TIGIT and anti-LAG-3. For example, for the colorectal cancer population, there's 2 ongoing phase 3 trials. One of them is Relativity 123, testing an anti-TIGIT plus nivolumab versus Rego or TAS-102. And there's another trial with also anti-TIGIT with pembrolizumab. And this is tailored to those patients with PD-1 positive disease in the 3rd-line setting. And then I would like to end with just highlighting adoptive cell therapy, because there are ongoing studies also looking at those. Beyond checkpoint inhibitors, there are personalized immunotherapy approaches using adoptive cell therapy with either TILs or tumor-infiltrating lymphocytes. And just a simple diagram here, to show what TILs are and how do we treat with TILs. So they're pretty much obtaining a sample of the tumor or a biopsy, and then culturing those tumor cells, culturing the tumor and the immune cells with an immune enhancer, and then selecting for those tumor-specific immune cells, and then expanding those cells and reinfusing them after doing lymphodepletion. And so it's kind of a, the reason I showed this graph is just to show the complex logistics in order to do TILs. But it is a fancy, personalized therapy, and there is an ongoing trial right now looking at this in all GI tumors, including colorectal cancer. The other type is using TCR or T-cell receptor, genetically engineered T-cell receptors or CAR T-cell approaches with either, as I said, T-cell receptors or chimeric antigen receptors. And in this form, what they do is they isolate T-cells from the peripheral blood, and then they engineered either the T-cell receptor or they engineered a chimeric antigen receptor, and then they expand those engineered T-cells and reinfuse them after preconditioning chemo. And so again, it's a lengthy process, very complex, and there's some financial toxicity and clinical toxicity we have to consider with those approaches. So this is the ongoing studies with TILs. One of them is in GI malignancies, including colorectal cancer, going at University of Minnesota, designed by Dr. Emil Liu, and it's currently ongoing. And the other one is the T-cell receptor gene therapy trials. There's two, as you see, one of them going on at the NCI. And the CAR T-cell therapy trials, there's many of those targeting many common antigens in GI malignancies like HER2, CEA, Claudin 18.2, AFP, and Glypican-3. So a lot of them ongoing, and we don't have any results yet, so we're waiting on that. And one thing to highlight just before ending here is the challenges with this. We think that this is a fancy therapy and personalized immunotherapy to patients with GI malignancies, but the thing that we have to consider is the efficacy may not be up to the fancy way we're showing it, because there's more factors than optimizing cancer cell targeting. The other factors is, the tumor microenvironment. So if you have a suppressive tumor microenvironments with T cells that are burned out, even if you engineer the T cells to target those, tumor cells, you might not, get the optimum response you're looking at, because that cell is either aged, burned out, or the tumor microenvironment is not permissive, immune permissive. And so things to keep in mind, in addition to the financial toxicity, logistics, and all of those things. And finally, beyond the novel approaches, with CAR T cells, engineering, and all of those things, we have to think about which population benefit. As you see in all of those studies that were presented, not everyone is benefiting from immunotherapy, and we are still lagging behind in identifying good biomarkers that tell us which patient will respond. And specifically for colorectal cancer, as relevance to stock here, colorectal cancer is one of the smartest tumors. It's very heterogeneous. There's multiple factors. We're talking about cytidness, molecular changes, RAS thing that could change things. A lot of things that would play a role in this heterogeneity beyond even the molecular space. But one thing to highlight here from the immunotherapy session is the TMB as an IO biomarker. As we all know, the tissue agnostic pembrolizumab approval based on high TMB was based on the Keynote 158. And we use pembrolizumab for colorectal cancer in clinic. The community physicians use it based on that cutoff of 10 mutation per megabyte. So anything 10 and above qualifies for pembro. One thing to consider is that study did not really have good GI representation. There's no colorectal cancer cohort in that study, which question, do we apply it? Can we apply it to our colorectal cancer populations? That cutoff really, the universal cutoff doesn't apply to colorectal cancer. We may need a higher cutoff. And so there are, several observational studies that questioned whether that low cutoff applies to our GI population, including colorectal cancer. And a recent study was published in Nature Genetics, looked at another way or approach and deciding which is the cutoff that decides the immunotherapy responders. And in that study, around 1,600 patients from 10 cancer types were tested or analyzed. And they used the top 20% as the cutoff point to decide the TMB cutoff for immunotherapy response. And as you see here in the forest plot, they came up with a different cutoff for every tumor type, and then they analyzed overall response, and they've seen a numerical trend of better overall response with a hazard ratio than 1 in nearly all cancer types. So showing us that using a different cutoff will better identify the responders. And with regard to colorectal cancer, as you see, the cutoff was 52, as opposed to the 10 that we are using, way higher. Even when we look at the MSI high population, there was a TMB cutoff that identified. So in that cohort with colorectal cancer, they isolated the MSI high population. And patients who have MSI high colorectal cancer who do not respond to immune checkpoint inhibitor, they have relatively low TMB, less than 37 to 42 mutation per megabyte. This brings up the question, is TMB a biomarker or a biomarker? So even within the MSI high population, we know that the response rate was not more than 50% in the KEYNOTE-177 study, something to keep in mind. And then ending with this slide, my last slide, machine learning approaches, which I think this is the future because of all the heterogeneity we're dealing with every disease, considering all of those factors, finding something that could keep all of those factors in mind and coming with a score that does not just look at TMB or MSI or like one marker, but look at all of them and then utilizing that score. So this is just an example of a study that did that, published in JETC 2020. They used, so in all of those machine learning approaches, you train the approach first in a discovery cohort. And if you see a difference, then you validate it in a different cohort. So they came up with this IO score. And as you see, it was able to differentiate those patients who respond to immunotherapy versus not. The hazard ratio was very positive, very significant, 0.22. And then they tested in the validation cohort and they've seen the same result. So this needs to be, again, they did this machine learning approach not in a prospective cohort, but retrospective cohort. So this whole thing needs to be validated in a prospective large study. So we're looking forward. I think the future is going to be something like that when it comes to biomarkers.
Thank you very much, Dr. Saeed. Questions from the panel first.
I think it's really important what Anwaar said though about TMB. We actually, so I sit on the SITC committee for immunotherapy, and we have guidelines coming out soon. And basically, we're not advocating for IO therapy based upon TMB for colorectal cancer because there were no colorectal cancer patients in that trial. And then they pointed out anal cancer, which also is useless because we know immunotherapy works, but it has nothing to do with TMB. It's because it's a virally driven disease. And I have published on it, other people have published on it as well. So TMB is very confusing for the colorectal space. It's a bit misleading the way the FDA approved it, I'll be honest.
Mm-hmm, mm-hmm. So one question that I have for Dr. Saeed is that for patients who want to consider a TKI plus immunotherapy trial, when do you think is a good time to look at it? Do you want them to wait till they progress on all lines or second line? Like what guidelines would you want patients to keep in mind?
So I think, most of those studies that we have right now is in the third line space, third and beyond. And so they will have to fail the standard of care, chemotherapy in the first and second line setting before enrolling on those studies. And if they belong to a subgroup that has targeted therapy approval, for example, RAS wild type, have to fail panitumumab or cetuximab with chemo prior to enrolling on those studies. And the reason for that is because we don't know whether those VEGF TKI, we don't even know the group of patients that will benefit from them. Some patients, actually most, may not benefit. And so it's hard to, consider those studies, for example, second line when we don't have any data showing that they trump the second or first line regimens.
Right. And the control arms on all of those phase 3 trials is either Lonsurf or regorafenib. And then obviously the Lonsurf one's probably going to have to be amended now to include bevacizumab.
Yeah.
Okay, and then what about the location of mets? Like, what about somebody with peritoneal disease or liver mets or say bone mets or soft tissue mets? I mean, what would they consider? What would they think about if they want to enroll in a trial like this?
I think right now, based on the ongoing studies that we have, we do not have really novel agents. This is really a hot area for research, and we really need studies tailored to deliver metastatic population. We do not have any, novel agent that showed really good results in patients who have colon cancer with liver metastasis. This is a great unmet need. The ongoing studies are pretty much all comer studies testing VEGF-TKI or IO, and there are a number of CAR T-cell studies as well ongoing for specific, biomarker. So I think if someone has liver metastasis with good, relatively young age, I would still consider those studies, or if there is a CAR T-cell study tailored to a specific marker, and that patient could go on that study, then that would be the what I would favor.
Okay. I would like to promote the fact that the HAI study is going to be opening up shortly, but that's for newly diagnosed patients. And then there's the Alliance trial, right, Josh, the Erasure study?
Yeah. Right. Yeah, for multiple sites of metastatic disease with the primary in place. And then the hepatic arterial infusion study that Dr. Ang is talking about can also be pursued with the primary in place, which is also liver-directed therapy, which is very useful and now open across multiple different sites across the country. So I think potentially very effective therapy.
Not open yet. Which you're talking about the to be open.
Yeah, to be. Yeah.
Okay, I think we can look at a couple of questions. One is like the grade 3 AEs from RIN seems to be higher regarding liver issues than I recall, than typical treatments. Is this something that is seen in other immunotherapy combination trials as well?
It is seen, but I think it's higher in the RIN because of the ipilimumab. It's a triplet combination. It's not a dual combination. So I think the ongoing study that is testing, comparing the triplet versus doublet should definitely question, quality of life, toxicity issues with a triplet regimen like this, because IO have a grade 3 toxicity of around 30 to 40%. Now we're talking about triplet, so.
Okay. And then the next question is, do autoimmune diseases such as hypothyroidism exclude you from immunotherapy?
I would say not necessarily. If you have a hypothyroidism and you are on replacement therapy and your thyroid function has been stable for the last month or two prior to enrollment on a stable dose of levothyroxine, that would not exclude. But if there is an autoimmune disease behind it, like Graves' disease, that would exclude patients.
There is a trial at the NCI right now, though, specific for patients with autoimmune diseases regarding the use of immunotherapy.
Okay.
It's ATCN study, right?
Yeah.
It's at ATCN, right? Within the ATCN network.
I don't know who's running it. I just recall that it's a NCI-sponsored study.
Okay. And then most of the AEs, can you get steroids, and would that take care of it?
I would say not most of them. Most of them, yes, if it's grade 1 or 2. For the grade 3 or grade 4 toxicities, we typically start with steroid, but depending on what happens next, if there's no response within 48 to 72 hours, we can escalate to more powerful cytotoxic agents.